What's the time? I need the time.
11:16.
11:16.
Yes, please.
I can get.
Yes. Yes, we can get started.
Okay, so a very quick discussion on one of the very critical emergencies in obstetrics, and that is shoulder dystocia. Shoulder dystocia is a horrible complication that at best needs to be avoided. And how best are we going to avoid it? Is by knowing that this mother, based on the risk factors that they have, is likely to develop it. Then you can think about it, be more prepared, and in better chances, even offer a cesarean delivery outrightly, even before subjecting the mother to an anticipated vaginal delivery. So now, Dr. Kaunga, the physician, do your fingers like this. Yes, up. So this is the maternal pubic symphysis, and we'll start by definition. So shoulder dystocia occurs when the fetal anterior shoulder gets impacted against the maternal pubic symphysis. Because the last time I checked, midwives deliver down to deliver the anterior shoulder, then up to deliver the posterior shoulder. But this is a baby that is impacted behind the pubic symphysis of the mother. And this is called the anterior shoulder because it's the one in front, and that's the posterior shoulder. But where you fail to deliver the anterior shoulder is called shoulder dystocia. Clear?
Yes.
And obviously, the temptation will be to continue pushing the head down and down. And we talked about this under breech delivery last time, that the fear you have with undue abduction of the head away from the shoulder is that you can damage the trunks of the brachial plexus. And this baby will end up with this type of deformity known as the Erb's paralysis. Now, rarely, shoulder dystocia does not refer to the maternal pubic symphysis, but it refers to a bone down there, which is called the sacral promontory. So the mother has got another bone here, which is part of the sacrum, and then proceeds to form the vertebral column up there. So the posterior shoulder would be the one which is stuck, but this is very rare. What is more common is the anterior shoulder. Thank you. Next, the other name for shoulder dystocia is the obstetrician's nightmare. Just like me, as a surgeon, my nightmare is DIC on the table. But for the obstetrician, it is actually shoulder dystocia, which is the obstetrician nightmare. So it's not a complication that we want to meet, and you will smile about it. Then, when it comes to epidemiology or incidence of shoulder dystocia, I would say that the incidence has markedly reduced because of the advent of cesarean deliveries. Almost everywhere people are offering cesarean deliveries, and now we are careful because we know the risk factors to shoulder dystocia. So there's no need for you to actually write because I've already written the notes, and I think they were posted in the group. So I'm just quickly recapping. So what are the risk factors? So these risk factors can be preconceptual or antepartum, implying that even before somebody conceives, you can actually be able to determine the risk. And the first risk, which I gave you, is the previous history of shoulder dystocia. If people tell you that I had a shoulder dystocia in my last pregnancy, then this particular pregnancy you will ever have should be a cesarean section. So that's one thing we say. Once a shoulder dystocia, always, not a shoulder dystocia, but always a cesarean section. Number two, it is the obesity. Number three, it is the diabetes mellitus. And we do know that even if that diabetes comes in pregnancy or it was there before, no wonder we talked about ovate gestation, the risk is high, and now we are moving in the antepartum. So, why is it that shoulder dystocia is common in babies born to diabetic women? We did mention when we discussed the lecture is that the mother has got so much sugar, and that sugar is transferred to the baby by facilitated diffusion. And the baby all of a sudden receives so much sugar from nowhere, but the baby has got no issues with insulin. So what is the baby trying to do is to raise its insulin level to match with the raised sugar, not so. And that rise in insulin, which is due to hypertrophy of the islet cells, will make the baby sustain the high sugar, right? But then what will happen when the baby is delivered? When the baby is delivered, there will be no sugar supplied to the baby, but there will be high insulin. And that high insulin will get all the sugar and push it back in the cells, and the baby will have hypoglycemia. No wonder hypoglycemia is common in babies born from diabetic. But now, don't forget, one of the effects of insulin is to cause fat production or fat deposition. And the fats will be deposited more in the shoulders than in the head and neck. So even a 3 kg baby of a diabetic mother will get stuck at the shoulder. Clear? Then you are getting the explanation. The other risk is the macrosomia. But of course, macrosomia is obvious. I think I did not put it in the notes. Obviously, a big baby will have a big body and to get stuck. So clinically suspected or scan suggestive macrosomia, think about distortion. The other one is post-death. So post-death is not good. The pregnancy going beyond 41 completed weeks, the babies get stuck. Finally, it's labor abnormalities. Any labor that requires induction, augmentation, or what we call secondary arrest. Imagine the pathograph is moving very well. Then just when you reach 7 centimeters, it gets stuck. That's called secondary arrest, and then it becomes a flat. That is a danger. That you end up with a dystotic bed. So it's called secondary arrest. Not the one where it's 4 centimeters and it's stuck 4 centimeters wide, but the one where it's progressing well and gets stuck at higher cervical dilatation. Or finally, I mentioned instrumental delivery or any such type of deliveries. So now, let's look at the sign. Again, I need your finger. So, how do you know that this could be shoulder distortion? Remember, the baby comes as descent, engagement, further descent. These are mechanisms of labor. Descent, engagement, further descent, it reaches the pelvic floor. Then it flexes. After it flexes, it undergoes internal rotation. Then extension. This is what we see when the baby is coming out. And that's where now the midwife will stabilize the perineum with pad, flex the oncoming heads, and then the baby props out. You wipe the face, you check for the cord. Then what do? We await for restitution before we complete the external rotation and the delivery. That's what we do in the bowel. Now, one of the things that you find is that this baby, after extension, it will come out, but it won't necessarily restitute. It will come out, then it will go back in again, and then it will go against the maternal thigh. It comes out, goes back in, and then goes against the thigh of the mother. That is called the turtle sign. Remember that movie called Ninja Turtle? The turtle is like a tortoise. How do you pronounce it? Tortoise. So it's as if it's brought its head and gone back in the shell. Okay, so that is a turtle sign. So if you want to see that on the valve, that's a sign that this will be a shoulder distortion. That's one. Number two is the failure of restitution. Remember, restitution is where the fetal head is trying to align itself with the rest of the body. So it makes either a clockwise or a slight anti-clockwise movement, but the baby fails to do that while you are waiting for restitution. That's also a danger. Finally now, what are the maneuvers? And I gave you very clearly. I said we follow what is called the helper approach. It's H-E-L-P, like help. Then E-R-R-R. If you want, you can put 3 R's at the end, or 2 R's, up to you, or 3. I think I gave you the 3. So what are the helper approach? It's been adopted by a number of obstetricians and midwives. The first one, H, is call for help. The second one is evaluate for episiotomy. So I'll send the notes. The L is leg. Lift the leg. It's to do with the leg. Then help, right? Then P is the pressure. That's suprapubic pressure. Then the other E is enter. Enter the vagina for internal maneuvers. Then the R, the first R is the remove the posterior arm. And the last R is the roll on all four. And then the last R, if you wanted now to include the last R, it is the rescue or resort, meaning the maneuvers of last resort. Now you are desperate because the situation is bad. So what are we going to do? First, when there is a shoulder distortion, because you are the one in labor wards, you are trying to deliver a baby. You nicely do this, the shoulder can't come out. Are you able to see from there? You can come this side. So you can try to do this, the shoulder can't come out. What you should do is don't do undue abduction for the risk of damage to the brachial plexus. So just leave that baby. The baby has refused. You shouldn't force matters. So what are you going to do? You are going to shout, shoulder distortion, labor ward, help! I'm telling you, even if I was about to deliver a placenta here, or I was about to write notes, or the way we are seated here, we need to all rush. That is a serious call. They've given us a diagnosis, they've told us where they are, and they've called for help. So we all land there. Now, there is not just the clinicians and the midwives and nurses. NICU, because there's potential birth asphyxia there. HIE. So even them, they should be there. Then when you arrive there, what are you going to do? The first thing, obviously, is to identify the team leader and then divide yourselves in groups, similar to what we discussed on postpartum hemorrhage. Because you can't have an emergency being done without a team leader. This one is hitting here, this one is abducting the... No. There must be somebody who is giving instruction. So the first thing that we're going to do, back to what we said, is evaluate for episiotomy. So what we mean by evaluating for episiotomy is that somebody should have already prepared the Lidocaine, maybe 1%, maybe in 20 mils, meaning 10 mils of each. You should have an episiotomy scissors, you should have some Savlon, a drape, and everything that you need to do an episiotomy. It's not mandatory that you should do the episiotomy, but it's up to you and your discretion to say, should I do it or not? Episiotomy will not help remove the impacted shoulder, but it will help you when it comes to internal maneuvers, which I will describe. So episiotomy row is just for internal maneuvers, if at all you will reach there. Because again, it doesn't mean that you do all the maneuvers. What if you just do 1 and 2, and the baby comes out, and then you did an episiotomy? So that is why I'm saying it's subjective. You have to understand. Now, the episiotomy, my teacher, who I'm very proud of, Ms. Garcia Mumba, the retired gynecologist, would always call it a generous episiotomy. Meaning, you do a bilateral episiotomy with a very wide space. Number 2, after we evaluate for episiotomy, then you go to the L, right? It's help, H-E-L. So I'm on L. L is the lift the leg, and that is known as the macrobats maneuver. So, Mtarekam, I'm not going to do it on the physician. You can sue me. Yes. No, you can sit. Just put your phone here. You just want to go that side. Go. No. Here. No, here. Hold her hand like this. And like that. Now you just want to describe the macrobat. So you need 2 people. Okay? You cannot do macrobat alone. So one will you need to remove the patient from the stair ups. Imagine you had put the patient strapped. So remove the mother from the stair ups and then face this side, like the one I'm facing here. So the first thing that you are going to do is flex the knees. Let's assume these are the knees, right? So when you flex the knees, it means then we flex the hips, right? So it's like you are doing this. These thighs, the thighs of the mother will come onto the abdomen. You get the point? Let's assume these are the thighs. So they will go on the abdomen. So there is flexion at the hip and at the knees. Clear? Then hold the thighs, like the legs like that. Then let's abduct. Right? And then let's laterally rotate. You are medially rotating. Yes, move a bit there so that people see. So this is the macrobat's position. Okay, let's go again. From the patient was like this. So what? Let's do it at the same. You should do it at the same time. Flex, abduct, and just slightly laterally rotate. So we leave the lady in this position. That is known as exaggerated lithotomy. Because imagine she's at the end of the lithotomy table and you've done that. So it's like you've pushed the pelvis onto the end and then you've pushed the limbs backwards. You get the point? Again, for last demonstration, flex, the thighs are on the abdomen, abduct, and slightly rotate. Okay? Yes, so that is a macrobat. So you maintain the macrobat position and the third person now comes to deliver the baby. Clear? Yes. That's the macrobat maneuver. What is the principle behind the macrobat? When you do this macrobat position, what you have basically done is that the pubic symphysis has been pushed upwards and on top. It's like it has gone backwards. Whereas the sacrum, particularly the lumbar lordosis, has been flattened. Okay, so this increases what's called the functional size, and the shoulders can then pass. Clear? That's a very important maneuver. It looks simple, but in about 70% of shoulder dystocia, it will release that strapped shoulder. Now, while you are maintaining the macrobat, but the baby refuses to still come out, what are you going to do? You maintain the macrobat position and then you apply what is known as the suprapubic pressure. Okay? Suprapubic pressure. So come, I can't apply suprapubic pressure. No, just move there. You can come in. So, the way we do suprapubic pressure is like those people have done, do like this. So, a third person, I don't know if it's now a fourth person, because the other one is delivering, not so. So the fourth person will come just above the pubic symphysis to do, you see, in the CPR position. But you will not be pushing in the median plane, but you will be slightly in this direction, and then you'll be doing this. Almost a CPR kind of, but on the abdomen. Okay? And that is known as the Manzanti maneuver, as also called the Rubin 1 maneuver. So Manzanti and Rubin basically refers to suprapubic pressure. What is the principle in suprapubic? Okay, we can go do the suprapubic, but where's the table? So the principle in suprapubic pressure is that you want to change the orientation, because the baby is like this. Right? So you want to change the orientation of this into that. From the pubic, put the pubic symphysis. From AP, oh no, don't want the baby. Yes. From AP, I want the baby to tilt. So no wonder I'm pushing at an angle so that the shoulders go oblique. Right? And at the same time, to some extent, you want to reduce the bisacromial diameter, the diameter between the acromial processes of the scapula. After the suprapubic, while those people maintain the macrobat position, the baby refuses to come. We are now going to E, not so? Helper. We are now in the first E. So the first E is called the enter the vagina for internal maneuver. So why are we saying enter? It's like you do a vaginal examination. So this is the pubic symphysis, and this is the baby. Of course, I can't deliver from, okay. All right. So in that case, the suprapubic person stops, not so? But you have still maintained the macrobus position. So what I'm trying to do before even I demonstrate it is that we want to move this arm to come in front and this other arm to go behind. You've seen this. So how are you going to achieve that? Imagine you can't even see this. So you are going to use 2 fingers. So you go 2 fingers, bypass the stack shoulder, and then you go behind the arm. And then you squeeze or flex your fingers so that this one comes in front. But maintain it, don't let go of that finger. Then push the other finger down, try to get hold of the other arm and push it behind. You end up with this. Right? That's called a Wood's corkscrew maneuver. Then in this position now, try to pull the baby. You are not using these angles of the mandible anymore, but you are now using the actual limbs. But as you are coming out, come out in a rotational manner. In fact, you don't even need to use a lot of effort rotationally, because baby itself will prefer to come out in a rotational manner. At some point I've seen when I've used this maneuver before, the baby would even come out facing the other side. The one that's called the Wood's corkscrew. Like some of you would take wine. Some of you they take wine now. Before. Yes. But here they pretend like we don't know this. So that's a Wood's corkscrew. Now, imagine the same maneuver, but you did it in the opposite. Instead of bringing this one forward, you bring it up, meaning the anterior shoulder goes back, and then this one comes up. And you are to do the maneuver in the other way. Then it becomes a reverse Wood's corkscrew, meaning the anterior shoulder has gone back and not going in front. And that is called the Rubin 2 maneuver. Remember, the Rubin 1 was on the pressure. Rubin 2 is a reverse Wood's corkscrew. So those are the 2 internal maneuvers. You don't need to do both, but you can choose one, whichever is convenient for you. I would personally prefer the Wood's corkscrew as opposed to the Rubin 2. So again, put your fingers there. So what we are saying here in the Wood's corkscrew is that the baby is stuck here. So 2 fingers goes, you make your fingers straight until you go behind, and then push forward but maintain tension. And then go backwards and maintain tension. Then since you've gone this way, then on your way out, try to be pushing the baby out in that way. Well, those people maintain the macrobat position. If that fails, we are on E, right? Then we go to R now, the first R. We said the first R is what? Remove the posterior arm. So what it means is that, yes, what the stabilizer baby did? Oh, she's managing. Okay. So what I want to do now is, let me see if I can deliver the baby. Instead of delivering naturally like me from anterior, let me deliver the baby posterior. You get the point? So how are we going to deliver the baby posterior? Now, you can't deliver a baby posterior like the way you do it anterior. You can easily dislocate the shoulder or the elbow joint. Okay, so what you should aim to do first is try to flex. So you go posteriorly and then you try to flex this arm, almost similar to the peanuts maneuver in the shoulder dystocia. Then you bring out this arm. So you physically go for the arm and remove it first. When you remove it, it creates space. Then now you can push down to deliver this one. Okay, that's what is meant by removing the posterior arm. I've seen some obstetricians who prefer starting with the posterior arm because it's an external maneuver before they go for the internal. Meaning after macrobat and the manzanti, instead of going into the vagina for Wood's corkscrew or Rubin 2, you will first attempt this posterior arm removal. It is called the Jacquemere's maneuver. The one who created this name. It's called the Jacquemere's or the Banun maneuver. But then let's just call it Jacquemere. Yes, so that is removing the posterior arm. That is the ARA. Then the next ARA is you tell patients to roll on knee or falls. This is what I was saying, that maneuver is usually confused with what people do in cord prolapse. In cord prolapse, you find somebody who's in the ambulance like this, with these elbows resting the anterior part of the body and then the knees down. That's not a knee chest position. A knee chest means the chest should be flat, so the patient should have their hands straight. The chest is down. You get the point? That makes the trunk to stoop forward. That's how cord prolapse is supposed to be. But if they do this, like a four-legged animal here, two L's and the other L's that one, that's called a gasking maneuver. That is a shoulder dystocia maneuver, which I'm now talking as the rolling on all four. So when you roll on all four, what would have happened is that the stuck baby, come and hold him tight. I don't know how you hold it. The stuck baby will be like this. Yeah, but now is the mother. So that imagine this is at the back. The mother is facing this side. The baby, the head becomes a tail. Not so. Because the legs are like this. They are four like that. So what you do there is, in that position, you try to, it's like you are trying to repeat the same procedures. You try to deliver first with the mother in a four-legged with the head that side. So you try to deliver here, the baby refuses, right? Then what do? Because you can't put suprapubic at the back. You can't do macrobat. So you just attempt to deliver. If the attempt fails, you can still do the Wood's corkscrew in that position. So you can try to bring this front, this back, and try to deliver from the back. If that fails, then you can also try to deliver the posterior arm. So at gasking stage, you repeat all the previous maneuvers, except for macrobat and the manzanti Robin one. But you attempt to do that. If that fails, we go to the last R, which is the maneuvers of last resort. Maneuvers of last resort. I don't know that the baby will still be waiting for you at that point. So the first maneuver is the symphysiotomy. So you get lignocaine, you infiltrate just above the clitoris, entering into the mons pubis. There you infiltrate with lignocaine. Then you try to do a VE or catheterize. Better still if you can use a metallic catheter. The rotunda catheter we have in theater, because that is strong. When you catheterize and then move laterally, it means you have protected the urethra. Then you cut the pubic symphysis, because the mother is now in the cotton. You cut with a knife. Okay? But you won't need to cut the entire length of the pubic symphysis. On its own, it will give up. Yeah, because of progesterone and the weakening of the pubic symphysis. Mind you, some people even have spontaneous symphysiotomy. Not so. After delivery, the bone separates. So even there just requires some weakening of that particular bone, and then you can try to deliver. That is a desperate situation. Because the mother will then be taken to those doctors who have screws and nails and those hammers. Maybe they can do something to put back the bone, or you can just put the patient on what's called a corset or a bed sheet and tie for 6 weeks. Then it will help bring back that pubic symphysis and the pain will resolve. So that is one. The other option you have is to fracture the clavicles. I've seen one doctor who likes doing that. So you fracture the clavicles of the baby, which are still behind the level of the pubic symphysis. You break them, and then you deliver. Clavicles, even if they are fractured, won't give any problem to that child. And then finally, you can consider doing what is called the Zavanelli maneuver. Zavanelli means that, like the way this baby is, you flex the baby first, then turn the baby into hospital anterior, and then push back into the vagina. And then go and do a cesarean section. So even at cesarean section, you can have assistance from behind, meaning somebody is pushing vaginally or somebody is trying to extract it abdominally. And that's the last desperate maneuver of last resort. Is the Zavanelli maneuver. And you can end there. Clear?